Good afternoon, everyone. Indeed, it is a pleasure to introduce Padma Shri Dr. Amit Maydeo. Maydeo sir is the winner of the World Cup of Endoscopy in 2012 at Chicago. He is the visiting professor at PGI Chandigarh and Harvard School of Medicine, Boston, USA. Sir will be talking to us on the topic Endoscopic Bariatric Procedures, a Critical Appraisal. Over to you, sir.
You may start your lecture, sir.
Can you see my screen?
Yes, we can.
So I'm going to talk to you today on endoscopic bariatric procedures, a critical appraisal. Now, as you can see from this slide, that obesity is on the rise in this part of the world. And in fact, if you see that especially in India, obesity has become in a tremendous magnitude. And it shows that around 75% of urban Indians are overweight. And you can see here that out of this, almost half of them are actually obese. And interestingly speaking, the maximum risk age is somewhere between 30 to 40 years. And you can see here that the average person goes from healthy at 26 to obese at around 38. Now, what is interesting to note is that obesity, especially in the Asian and the Indian population, is what you can see in these two pictures here. That is, predominantly in India, we have what is called as central obesity. So it is not only central obesity, which is around the tummy, but it also affects the peritoneal organs, the viscera, and that can also lead to early changes of fatty liver. And of course, obesity leads to its various problems like the metabolic syndrome. It can lead to type 2 diabetes, the dyslipidemia, increased risk of cancer, mood disorders, heart disease, etc., etc. Another interesting issue is the incidence of type 2 diabetes. Now, this is from a recent publication from Nature Review, and you can see here that in fact, India is slowly emerging to be the epicenter of type 2 diabetes in the world. And more than 60 million, 70 million people are affected in India with type 2 diabetes, what was originally called as maturity onset diabetes. And the main reasons for increased incidence of type 2 diabetes in Indians, it could be genetic, it could be environmental factors, of course, the changing lifestyle of Indians, changing dietary habits, and another contributing factor is, of course, the increased obesity. Well, in fact, this is a new classification of BMI, mainly for Asians and Indians, which was brought out by WHO recently. And you can see here that, interestingly speaking, that especially in Indian people, predominantly because obesity is central obesity, visceral obesity, even if you have a BMI as low as between 25 to around 30, these people can be classified as moderate obesity, and they have a moderate risk of developing comorbidities like various other problems, and especially fatty liver, and then they go on to develop non-alcoholic fatty liver disease. And above 30, if the BMI is there in Indians, mainly again because of visceral obesity, they are likely to have a severe chance of developing a comorbidity. Now, what is the treatment for this? A very interesting slide which shows that how much amount of weight loss is actually required to reduce the complications of obesity. The various complications, as you can see here, as written on the left side, it can be diabetes, it can be hypertension, dyslipidemia, increased HbA1c, sleep apnea, NAFLD, joint pain, stress incontinence, GERD, and PCOS. You see here, overall, if you go to see, the average amount of weight loss which is required to benefit and to drastically reduce the chances of complications is around 10%. Especially in type 2 diabetes, you see here 3% to 10% reduction of weight loss can also cause a significant or a drastic reduction in the comorbidities. And even if you have a reduction of around 10% of weight loss, you can actually reverse early fatty liver. Well, there is no doubt, therefore, this is the reason that lately, over the last decade or maybe couple of decades, bariatric surgery has started playing a major role in the treatment of obesity as well as the treatment of type 2 diabetes. And various types of bariatric surgical procedures are being performed for all these indications. And the most commonly performed bariatric surgical procedure is, of course, a laparoscopic sleeve gastrectomy. You can see here the incidence of lap sleeve gastrectomy out of all the bariatric surgery procedures is around 60%. And of course, you can do other types of procedures which are predominantly metabolic procedures which are aimed at reduction of type 2 diabetes, like a gastric bypass. You can see a Roux bypass. It can be a mini gastric bypass, or it can be a duodenal switch. Various things are possible. The problem is that in spite of the fantastic work which the bariatric surgeons have done in our country over the last decade or so, unfortunately, bariatric surgery, people do get scared of this surgery because it is a little bit big surgery, and there are some associated complications, though in the skillful surgeon's hands, these chances of complications are considerably low. But in spite of all this, the penetration rate and the acceptability rate of bariatric surgery in the Indian population is actually less than 1%. So therefore, a majority of patients who are obese or who have type 2 diabetes ultimately don't undergo any sort of treatment, and then they go on to develop a metabolic syndrome. And this is exactly the place where a bariatric endoscopy may be useful, sort of meeting the unmet need. And the first endoscopic procedure which can be done in bariatric endoscopy is a gastric space occupying therapy in the form of gastric balloons. Now, this is not a new treatment. Since many years, endoscopists have been placing balloons inside the stomach so as to occupy the space in the stomach, and thereby this causes the stomach capacity to be filled with the balloon itself, and therefore the patient eats less, and therefore the patient loses weight. Variety of balloons are available in the market. These are the two types of balloons which I have marked. The Orbera intragastric balloon and the SPADS adjustable balloon system are the two balloons which are commonly used in our country. Different types of balloons are there: air-filled, fluid-filled, refillable, swallowable, etc. In fact, new balloons have come where the endoscopy at all is not required. Patient just swallows a small capsule type of a balloon, and once the balloon enters the stomach, it can be inflated and it can be disconnected. And later on, once the balloon does its work, after a few months, the balloon automatically disintegrates and passes out through the intestinal tract. However, this is still not available in our country, still in experimental stage in the United States. These are the two types of balloons which are commonly used. And nowadays, the most commonly preferred balloon is the Orbera intragastric balloon, which is a fluid-filled balloon, and the optimal amount of fluid that we fill inside the balloon is around 400 cc. Placement of a balloon for therapy is an extremely simple procedure. It can in fact be done on an outpatient basis. The balloon assembly is attached to the scope, and both together are passed inside the stomach, and then the balloon is inflated. And after inflation, the attachment is disconnected and the balloon is left inside. And once the work of the balloon is over, after a few months, all that we can do is go inside, aspirate the balloon out, and then we can catch the balloon by means of a special grasping forceps, and then the balloon can be taken out. What about the results of balloon placement? You can see here a very good paper which was published by the Brazilian Intragastric Balloon Consensus Society. There's a statement which came out from there. More than 40,000 cases of balloon placement, intragastric balloon placement in Brazil. Average volume which was recommended was 400 cc's of saline. And you see here a total body weight loss could be achieved over a period of 6 months of 18.43%, with a significantly low adverse event rate of only 2.93%, and therefore balloon placement is a very good alternative for a temporary reduction of weight. However, the problem of balloon placement is that after 6 months or maybe 1 year, we have to take out the balloon, and once the balloon is taken out, there is a possibility that the patient's weight can again gain up. So after a month of gap, we can again replace and put a new balloon. However, this patient will need repeated placements of balloon in case you want to achieve a sustained weight loss. So we nowadays reserve balloon placement for those patients who do not want any other major interventional therapy, either endoscopic or surgery, or if you have young girls who are overweight and they want a temporary reduction of weight because they want to get a job or they want to get married. So there is a good placement. You can do a balloon placement. You can achieve a reasonable reduction of weight over a period of 3 to 6 months. And then if the patient follows a proper lifestyle management, then the weight reduction can be further maintained. The second endoscopic procedure which can be done for obesity is gastric restrictive procedure, where we actually reduce the size of the stomach by using an endoscopic method instead of a surgical method. This has become possible only because of the availability of the suturing device which can be attached to the tip of the endoscope. Now this suturing device, which became available in our country only a few years back, is called as the Overstitch. It is made by the Apollo Endosurgery Company, and you see here this device is attached to the tip of a double channel endoscope, and this is exactly how the procedure is done. The suturing device is attached to the tip of the scope, and then we go inside the stomach. You can see here that this is the stomach, and then by using a superficial laser like the argon plasma coagulation, we can do marking on the anterior wall of the stomach and the posterior wall of the stomach, and this is the suturing device which is attached to the tip, and then we can take full thickness sutures starting from the anterior wall, going on the greater curvature, coming on the posterior wall, and again in a U-shaped fashion we go up, and thereby we suture, tighten the knot, and we can plicate the entire greater curvature of the stomach in a full thickness manner. You can see here from this cartoon how the stomach has got plicated. In these type of procedures, we intentionally leave a part of the fundus intact. This is how the mechanism works. That is the needle driver. That's how the needle is attached to the needle driver. Then by using a screw type of a device, we can push the screw, enter the wall of the stomach, and pull the wall of the stomach between the two towers, and then the needle is passed through and through the entire wall, and this such type of way we can take a actual suture, and by this we can plicate the greater curvature of the stomach. The first paper on endoscopic sleeve gastroplasty was published by this gastroenterologist from the Mayo Clinic. You can from it published in GI Endoscopy. You see here. And after that, very soon, this procedure was taken up by endoscopists from Brazil as well as from Spain. And you see from this radiological picture, after a sleeve gastroplasty, how much the size of the stomach has reduced. It has almost become like a tube, and therefore the capacity of the stomach reduces, and the patient starts eating less than 50% what the patient used to eat before. After its invention in 2013, in 2015, in SAGES, a multi-center trial was published by these 4 centers, and you see here the results at the end of 1 year. Initial BMI of the patient was around 35. You see here the average weight loss at the end of 1 year was 17.6 kgs, and so this was a total body weight loss was almost 18 to 21%. So this was a very good result, as you can see from this. The main advantage of the endoscopic sleeve gastroplasty as against a laparoscopic sleeve gastrectomy is that with an endoscopic procedure, we maintain the anatomic structure of the stomach, we maintain the innervation, we can maintain the blood supply. It is a potentially reversible procedure. It is a reproducible procedure. It is repeatable if required. That means if some of the sutures loosen up, we can go in after a few months and go in and take 1 or 2 more stitches and again make the stomach into a tube. It is extremely safe. In all the published literature so far, there have been no adverse side effects, and it is more durable than the balloon, and it of course can be upgraded by surgery in case you do not get the satisfactory result. If you ask me, what is the real role of endoscopic sleeve gastroplasty? I'll come to that, but you can see from these radionuclide studies that after endoscopic sleeve gastroplasty procedures, 2 things happen. Number 1, the capacity of the stomach reduces, and number 2, it also reduces the stomach gastric emptying. You can see from this radionuclide scan that the amount of content of food which is remaining inside the stomach is much more. At the end of almost 5-6 hours, the patient does not feel hungry because the food tends to remain in the fundus of the stomach because there is a delayed gastric emptying. So the result of ESG is not only because of reduction of the size, but it is also because of increasing the reducing the gastric emptying of the patient. This is how the actual procedure is performed. This is how the suturing device is attached to the tip of the endoscope. This is the screw type of a device by which we are going to go inside the wall of the stomach and then pull the wall inside the 2 towers over here. You can see now we are going to pull this inside, and by pulling, then I press the handle and the suture goes through and through the wall of the stomach. And here you can see now that the first suture has been taken, and this is just on the anterior wall. So we can keep on suturing like this, and as we keep and go down, we take a U shape, and as we make a U, you can see here that the first plication can be completed, the entire plication along the greater curvature on the posterior wall. And if I come over here, now you will see that at the end of the suturing, if you compare before and after the suturing, you can see here that before the suturing, the stomach is wide and dilated on the left side, whereas after the suturing, you can see that this is almost like a tube. So therefore, on passing the endoscope inside, you can actually make out this appears as if you are looking inside a patient who has undergone a laparoscopic sleeve gastrectomy. So here is the sutured stomach. This is the normal stomach. So this is the procedure of endoscopic sleeve gastroplasty. A very good meta-analysis published in this year, February 2020, a meta-analysis of 11 studies, 2,170 patients of endoscopic sleeve gastroplasty, 7 single-center studies, 4 multi-center studies. You see here the average BMI pre-gastroplasty was 35.7. Total body weight loss at 6 months was 15.3%, at 12 months was 16.1%, and 18 months 16.8%. Excess body weight loss almost 73% at 18 months. No serious side effects and no mortality. Our own patients, 203 patients from March 2017 to February 2020. You see here that average number of sutures were 4. Average total body weight loss in 2 months was 12%, 6 months was 17%, and 12 months was 19%. In fact, in one of the patients, we could achieve a 21% total body weight loss or 25% total body weight loss, where the patient also had an extremely good compliance to various diets. The next endoscopic procedure is gastric restrictive procedure, similar to endoscopic sleeve gastroplasty. This procedure is still experimental and only a few procedures have been done. This is called as the pose procedure, or it is also called as the primary obesity surgery endoluminal procedure. Similar to the ESG, but a different type of a device, and instead of actually suturing, this is just a plication. So multiple plications are done inside the stomach, and because of these plications, the stomach gastric emptying reduces. There is a delayed gastric emptying, and this causes a reasonably good weight loss. You see here from the single center experience of 73 patients, a total body weight loss of 15.7% at 6 months. The next procedure, which is a very funny procedure, very unique procedure, mainly done in the United States, is a gastric content reducing procedure called Aspire Assist. Now this sounds very funny, but in this procedure, what the endoscopist does is actually performs a gastrostomy, an endoscopic percutaneous gastrostomy. So we perform a gastrostomy, passing an endoscope inside the stomach. We inflate the stomach, and then through the stomach, we pass a railroad tube. That tube comes out through the stomach, comes out from the anterior abdominal wall, and then that tube is cut there, and you attach it to a button. And then what has happened is, what the patient has to do is, the patient can eat normal food. Only thing the patient has to do is chew the food properly. And after eating the food, after maybe half an hour or 45 minutes, the patient aspirates almost 3/4 contents of what the patient has eaten. And by this, automatically the nutrition goes down and the patient loses weight. And the main advantage of this procedure is that the patient can eat whatever the patient feels like eating. There is no dieting required. Lifestyle management is not required. The only problem is that this is the interventional procedure. There is continuously a button on the anterior abdominal wall. Therefore, it can be very discomforting. In fact, you can see from this paper which has been published from the University of Washington, this was also a randomized controlled trial of this novel endoscopic therapy. You see here a good relief of weight, excellent weight loss. You can see here almost 50% weight loss. You can see of excess weight loss, and a 30% of total body weight loss. But the problem is pain. There can be pain at the place of placement. Some patients have found irritation. Some patients have had peritoneal bleeding. So therefore, this procedure is not very easily acceptable. What is most important is metabolic endoscopic procedures is the procedures which are now coming up in a big way. And the first procedure is a procedure which is aimed at bypassing the foregut. The mechanism of this procedure, which are done endoscopically for the treatment of type 2 diabetes, is aimed at this part of the foregut. Now, it is now conceptualized or hypothesized that one of the main reasons of type 2 diabetes is because of abnormal enteroendocrine cells which are present in the foregut, especially in this portion, and thereby these patients develop insulin resistance. So now, if you can bypass the foregut, and if the food without the nutrients don't come in contact with the abnormal cells and they go directly to the distal gut, maybe you can have an improvement of the metabolic problems. So therefore, a procedure was developed by which we can bypass the foregut, and this procedure is called as an endo barrier. And this type of a sleeve can be placed endoscopically. So this is a silicone sleeve. You can see here, long sleeve, and here is a anchoring mechanism. Now this anchoring mechanism is placed in the pylorus, and this entirely goes through and through the duodenum into the jejunum beyond the DJ flexure, and thereby it bypasses the abnormal enteroendocrine cells. And by doing this procedure, this is how the endo barrier is placed. By doing this procedure, it is also done endoscopically. I'll skip the slide. There has been on the initial studies results after 1 year, marked improvement in the HbA1c, you can see over here, and there is a robust continuous weight loss also. Why? Because these patients, the food doesn't get properly digested, because it doesn't come in contact with the bile as well as the pancreatic juice, and it directly enters the later part or the distal part of the jejunum. Of course, the problem of this procedure is the device. Though initially there were a number of publications of the endo barrier all over, the problem was this anchoring mechanism in the pylorus started giving trouble, because the anchoring mechanism had spikes. It caused a little bit of a perforation, and therefore some of the patients, the patient had a lot of pain, nausea, vomiting, early removal, migration. Some patients in fact developed liver abscess. Therefore the trial which was started in the United States had to be prematurely stopped, and presently the endo barrier device is in the stage of modification so that we make a safer anchoring mechanism which prevents these problems. A more interesting development which is now coming up is, of course, changing the lining of the proximal gut. Now this procedure is called as duodenal mucosal resurfacing. Now this procedure entails the principle. Similarly, it is done endoscopically, and what is done is endoscopically you go across the duodenum, go across the DJ flexure, place a guide wire, and then over a guide wire a device is placed. Now in this device, what you do is, first we inject some normal saline in the submucosa of the foregut beyond the ampulla of Vater. So beyond the ampulla of Vater till the duodenojejunal flexure, we inject some normal saline inside the submucosa, and after that we place a balloon catheter and inflate the balloon, and inside the balloon we fill it with heated water which is heated up to almost 80 to 90 degrees centigrade. So with which what happens is the mucosa gets ablated, and along with the mucosa, the abnormal endocrine cells also get ablated. And after 3 months, new cells come up, which are good cells, and thereby, if you perform a long distance ablation, we have found a very good result of HbA1c. You see here, this is how the procedure is actually performed. This is the actual device, that's the balloon catheter, and you can inflate that balloon. These are the aspiration ports. You see here, first sizing is done. And after inflation of the balloon, here from this area, a needle can come out and we can inject in the submucosa. And this is the balloon inside which we are actually filling it with heated water. And this is how the procedure is done. The guide wire is placed. After the guide wire is placed, then the injection is performed. And after the injection is done, then the balloon is passed inside, it is inflated. And by area, beyond the ampulla of Vater, you keep on ablating the area of the duodenum. You see here, these are the endoscopic pictures. This is pre-procedure. This is during the procedure, expanded duodenum. This is how it looks after ablation of the duodenum, 1 month after follow-up and 3 months after follow-up. Now, this was the first in human study. You can see here, this was performed in Chile along with some colleagues from Brazil. And from this study, you can see it has two effects. Number one, it has effects on the HbA1c, and it also had effects on the hepatic transaminases. So especially in those patients who had abnormal liver function with fatty liver, there was a reversal in the fatty liver changes, as well as reversal in the abnormal liver function. You can see here from this study. And of course, this study was only performed on 34 patients. This was a very initial study. Presently, a large multicentral trial on duodenal mucosal resurfacing is underway in Europe and United States, the results of which will be published after 1 year, after which probably this device will become an extremely useful tool for the treatment of patients of type 2 diabetes. So instead of subjecting them to a major bypass surgery, maybe we can just change the abnormal enteroendocrine cells of the foregut by performing this procedure, and these patients may have a long-lasting benefit. Finally, ladies and gentlemen, a final endoscopic procedure which actually mimics a surgical bypass is a magnetically performed jejuno-ileal bypass. What we do in this procedure, we place one magnet in the jejunum, which is a hexagonal magnet like this, and we can place another magnet in the ileum. And because of natural attraction, these two magnets come near each other, and then what happens is the area between the two magnets automatically necroses off and perform a natural jejuno-ileal bypass procedure. The surgery of jejuno-ileal bypass was discarded many years back because surgeons used to perform an end-to-end jejuno-ileal bypass, which caused a very drastic malabsorption. This is a side-to-side jejuno-ileal bypass. So because of which what happens is there is not too much of malabsorption, but there is a very good effect on the reduction of the HbA1c. The main mechanism of action is that food does not come in contact with the foregut. It directly comes in contact with the hindgut, and because of the hindgut, the GLP level increases and therefore the insulin sensitivity improves in these patients. So this is how two magnets are placed. And then once the magnets are placed, you leave the magnets inside, cut these two threads from both the enteroscopes, and you see what happens. In day 1, there is a lot of inflammation, and day 2 and day 3, there is necrosis of that area. And then slowly, once the natural anastomosis forms, then the magnet both together passes off in the ileum and goes out through the stools. And you see here the food, partially it enters the jejunum, partially the food goes into the ileum. Now this is a magnetic jejuno-ileal bypass. This is how it actually looks from inside an endoscope. You see here, this is how it looks. We are releasing the magnet in the jejunum just to show you how the magnet is released. And once the magnet is released, we can cut these threads. Similarly, by using an enteroscope passed from the rectum, we can release a magnet in the ileum. Similarly, you can see when the same patient we perform a laparoscopy, you can see how nicely the anastomosis has been formed, a magnetic anastomosis. This is how it looks when you put in a laparoscope. Now, this anastomosis is not surgical. It is an endoscopically performed magnetic anastomosis. And this is an enteroscopic picture. We are going through the anastomosis, and this is a barium picture. Well, therefore, ladies and gentlemen, what I want to tell you is we are now facing a major pandemic of obesity as well as type 2 diabetes in our country. Unfortunately, presently, we are facing a different pandemic, that is of corona. But of course, we don't have to forget that diabetes as well as obesity is something which is a reality, which we'll have to tackle once things become a little normal. Even though diet and exercise is the prime thing what these patients have to follow, it is easier said than done, not so easy to follow. Bariatric surgery is wonderful, the results are superb, but very less patients accept bariatric surgery, they get scared. So therefore, one of the futures I personally feel is going to be bariatric endoscopy. Thank you for your attention.
For a wonderful talk. The videos themselves were so lucid that they took us through this journey beautifully. Thank you so much for that. We have very little time. One question that I have received here is, you mentioned that young girls or boys who are going for work, marriage, they can go for a balloon procedure. How young? So is endoscopy bariatric surgery an option for children, childhood obesity, or young people? Is there an age bar? Any studies on that?
Well, normally we don't do it in very young children. So normally these are young adults, we can say. So these the break-off limit is somewhere around 15 or adolescent age. Beyond that, we use these techniques. In very young children, we prefer to, even if we do place a balloon, these balloons have to be placed with a lot of care because cannot inflate the balloon too much. These children may not tolerate the balloon so well. But in adolescents onwards, we can place the balloons very, very safely. And it's an excellent treatment modality. It's virtually no side effects.
But it is temporary, you said.
Yes, it is temporary.
So again, lifestyle and everything will have to be set in.
Very important because you have to take out the balloon sometime or the other. So gastroplasty becomes a better option. Gastroplasty is a very safe procedure. In fact, the patient can be discharged on the same day or the next day. And there is no cut on the body. This doesn't look like a surgery. There is no removal of any part of the body. So therefore, the stomach maintains its own function. Everything remains okay. Only the size reduces and the gastric emptying comes down.
I think we do not have time for more questions. This was a wonderful session. All the questions will be later on covered on our website. Thank you so much.
Thank you so much, sir. Thank you.
Thank you.